Got it. How's everybody doing? It's been a minute. It's been a while. And we are here today. We're going to have an exciting day, as always, on the Appalachian Partnership Consortium call. I'm super excited today because I get to talk to an old friend, and he is old, and a new friend who's not old. But, we also get to talk about a topic that I think for those of us in the Appalachian region is probably a decades old fight, a decades old conversation where we don't get a lot of traction or attention of the impact of hepatitis. And I think that, if you look at a lot of the data, what happens is that you see that West Virginia and Kentucky vacillate between 1 and 2 and have done so for a number of years. And some would dare say decades. Some say more because of underreporting. Some say more because of, improper surveillance systems and that sort of thing. But I think that if we look today, we really do see West Virginia, Kentucky, and this region of the world heavily impacted by hepatitis C, primarily a lot of it driven by injection drug use, substance use disorder. There is now the state of West Virginia has codified its hepatitis C elimination plan. The nation has a hepatitis C elimination plan. So I thought it was high time we talked to some folks that are here about hepatitis C, what we need to do, what the plan is, and realistically, can we eliminate? And because these are called elimination plans, these are not called education plans or treatment plans or anything like that. So the goal here is to eliminate hepatitis C. And now, I usually take a lot of liberty on these calls, and so I'm going to take one more ounce and one more step of liberty here. And that liberty is that I have a core belief, and I hopefully have tried to kind of infuse this into us as an organization. And that is that I believe that, this 50% of Hep C cases that we say we can't find in the nation and we're not treating in the nation, I have a core belief that these cases are within our MAT facilities and that we have not done enough to actually engage MAT providers as a part of our continuum of care, treatment, and cure of hepatitis C. And that they should be integral parts of any elimination plan, any elimination strategy as we move forward. That is my nickel's worth. That is my opinion. And as everybody knows, this is my call, so you can't stop me. And there's nobody to hit a mute button, but here we go. So now, what I'd like to introduce is some of my friends and hopefully old friends, literally, and new friends. So I'm going to start with Daniel Raymond. Daniel, you can tell people where you work, but tell the people who you are. And I think that that's a bigger story.
Okay, lots of different ways to tell this story, but I am somebody who's worked in public health and harm reduction for a long time. Getting my start in the early days, the height of the AIDS epidemic, when I got involved with ACT UP New York, a direct action group that was committed to ending AIDS. And back then in New York City, this was before the HART era, the kind of cocktail era. So people were maybe taking AZT or maybe trying DDI, some pills that had some antiviral activity against HIV for a little while, but then HIV would get resistance to them. And a lot of people were dying, but in particular, a lot of people who were injecting drugs were getting infected and getting sick with HIV. And there was not a whole lot that was being done. So I got involved in the fight to establish legal syringe services programs. Back then we called them needle exchange programs, and found a passion for that work and for harm reduction more broadly. I have my own history of injection drug use myself that kind of fueled my commitment to it, but the work I did in HIV activism was a kind of springboard to a lifelong kind of commitment to people who use drugs and other intersecting groups that are vulnerable to oppression and structural violence. And a lot of that led me into hepatitis work. Um, I am currently the director of policy for the National Viral Hepatitis Roundtable, and I see my counterpart, our director of programs, Adrian Simmons, is also on the call, which is an umbrella organization that was designed to align and catalyze action around viral hepatitis, hepatitis A, hepatitis B, hepatitis C. There's increased interest now in hepatitis D. And we're about 20 years old, and we've become a program of hepatitis education project in Seattle. So that gives us lens to a lot of great direct services work that's happening at the local and county level. But, you know, I got really excited when World Health Organization back 6-7 years ago said, hey, we've got the tools to eliminate viral hepatitis, which they defined as a 90% reduction in new infections and a 65% reduction in deaths. And so they were talking about how that was achievable by 2030. And the way that that folds into this conversation is that the United States has also committed to doing that. And Tony, you kind of preface a question about, is that possible? And we can talk about the possibility of it. People who have been working on ending the HIV epidemic understand that we're not talking about eradication. We're not talking about zero virus anywhere in the 50 states, Puerto Rico, Guam, all of that stuff. But we are talking about eliminating it as a public health threat. And that is an attainable, ambitious goal that that we work on every day.
Perfect. Thank you, Daniel. And now I want to introduce my new friend. He doesn't know how this works. He doesn't know once he comes on this call, he's in the mob and the CED mob for the rest of his life. He didn't even know. Somebody didn't tell him. Sorry about that, Tim. I was talking to you. You're like, I don't know who she's talking to, but I'm talking to you, Tim. So can you introduce the folks who you are, a bit about where you work, but who are you? Who's Tim?
Right. Tony, thank you so much. And yeah, no, I already got quickly indoctrinated because I was on Capitol Hill with Patrick and Lee recently, and they wrote me right into this meeting, and I was eager to and willing to join. So I have been working in advocacy around biomedical research in general, as well as higher education my whole career. I guess I'm an advocate. That's who I really am. And especially around issues like Hep C, where I feel like we could make a dramatic impact across the nation, if not the world, in eliminating Hep C. And I like to work on those big projects. I worked for Dr. Francis Collins when he was head of the Genome Institute, when they completed the Genome Project, excuse me. And I have worked on genetic non-discrimination legislation related to that. I've worked on the stem cell, embryonic stem cell issue, and avoided Congress banning embryonic stem cells. So I view this as another great opportunity to work with Dr. Collins and all of you to try to make a major impact nationally on a disease that can be eliminated.
Well, I mean, thanks so much, Tim. So you probably know a good, I won't call him a dear friend because he'd probably say, we're not really friends. But Dr. Henry Masur, who was at NIH. And, you know, and I bring up Henry or Dr. Masur in this context only because when more than a decade, we pivoted our work from a very urban environment in Washington, D.C., to working first in West Virginia and then more broadly throughout the entirety of the Appalachian region, which is 26 million people, 13 states. One of the first phone calls I made was to Henry and to say, Dr. Masur, what do I need to do to eliminate hepatitis C in West Virginia and subsequently in Appalachia? And what was funny is that I was calling him based on the CDC 220 most vulnerable counties report and an article that had just come out in the Wall Street Journal and some information that I had gotten and received from Karina Dan, who used to work at HHS. So she had sent me all of this stuff. about what was happening in West Virginia with regard to then hepatitis C. But I put my public health cap on, and I was like, well, if this is what's happening with Hep C today, by a public health measurements, in 3 to 5 years, we should be seeing an HIV outbreak somewhere along this path. And that's exactly kind of what happened. But back to the story. I called Henry, and Henry said to me, and if you don't know, he has this like baritone voice. It's like, I don't know how to tell you this, but I would like to tell you that the chances of elimination of hepatitis C in the state of West Virginia will cost tens of millions, of hundreds of millions of dollars, and no one's going to give you the money to do that. Return to the District of Columbia, where you have the opportunity to truly eliminate hepatitis C. And I was like, yeah, Henry, that's not the plan. I can't do that. So I said, all right, but I'm going to stay here and fight. And he said, I know. And so that was, I think 7 years ago or more or better. And so here is where we are today. I think fighting a good fight, having gotten the state to pass an elimination plan, having the state see how critical it is that we educate, train professionals, but also educate, treat, and cure hepatitis C. So what I'm going to do is I'm going to ask you both to tell us the state of hepatitis C elimination strategy and planning in the United States. Daniel, don't take up all the time, but I'm going to let you. So in that case, I'm going to let Tim go first because I know what Daniel will do. Tim, this is a test.
Yeah, I'll be pretty brief, and then Daniel can jump in. But I'll just give a quick update on where we are in terms of the plan that was developed by Dr. Francis Collins when he was the science advisor to the president, and he's the former NIH head of the NIH. He developed a plan that was in President Biden's FY24 budget proposal that went to Congress, and what it would do would provide $11 billion investment over 10 years to pursue this effort to eliminate Hep C. Now, when we think of the cost of that, we're thinking about $8 billion a year is currently spent on Hep C. So adding, $11 billion to the budget in order to eliminate it would reduce that cost on the government and on all of us. So it's really a worthy investment. So once that was in the budget, now it's up to Congress to fund it, right? And we've formed a coalition of over 125 groups, and CEG is part of that. And we've been advocating on Capitol Hill, urging them to introduce the legislation that would fund this program. And at the moment, the Department of Health and Human Services has provided technical assistance to two senators, Senators Van Hollen and Senator Cassidy, Van Hollen from Maryland, Cassidy from Louisiana. And they are both working on different bills. That just reflects how Congress is right now. But they're both determined to come up with a piece of legislation that could get passed by Congress. And I think they'll work together eventually. Representative Hank Johnson in the House side, who's a Hep C survivor, will also be the champion on the House side once there's a Senate bill. So we're pretty optimistic that there will be a bill in the fall, ideally in September.
But Tim, David, I don't know if they told you, but I interrupt people all the time. So they
Sure.
should have warned you about that one. So
No
what's in this bill? You're saying that there's a bill. Is it like a sausage bill? Is it like a bill that says everybody gets free Hep C medicine? I mean, what is this? What's the bill say?
Yeah, I'll let Daniel answer some of that too. But so we don't actually have the bill yet, right? We know that the president put out a very specific plan in his budget, but it didn't have all the details about what you're asking for. So Department of Health and Human Services, as I said earlier, has provided technical assistance to the senators in order for them to write the bill, which we hope to see soon. Now, what did it have in there? It had an effort to create a test for immediate testing for Hep C. So you could go into a clinic, get tested right then and there and know if you have Hep C. Then it would provide a drug. There are 2 drugs on the market that would eliminate Hep C in 12 to 18 weeks. And that would be negotiated with the drug companies in terms of bringing the cost down so that it could provide for those who can't afford it, or those who are in prison, or on a Indian reservation, those kinds of things. So that's what was in the original plan. We have yet to see the actual legislation, so we're hoping to see that soon. And I just want to add one more thing before I turn to Daniel, and that's just that there's a unique funding mechanism. This is not the typical appropriations process that many of you might be aware of, where Congress provides the funding through an appropriation. It's on the mandatory side, or the Medicare and Medicaid side, which we think would be a more effective way to fund this and get this project going. So I hope I didn't talk too long, but that's where we are with things.
So here's my question, and maybe Daniel, you can kind of lead in with this, is that will there be an impact on this bill or on the 11 billion based on what we've seen on, some people call it a clawback, some people call it a comeback. No, just kidding. Some people call it a clawback, and some people call it rescission. Some people call it just the response to the debt ceiling. Do you think that will impact the president's ask for the 11 billion? Because it seems like HHS is slicing and dicing wherever they can, immunization programs, all of the COVID money. So do you think that this will get hit by that?
So I'm going to hedge my bets and say maybe. I think there's 2 broader points. One, the environment that you're talking about, Tony, in Congress is about we've been spending too much, our deficit's too high, we've got to cut the budget, we've got to trim the fat, we've got to scale back. And so that's not a good time for anybody to propose new spending. The bill that we're talking about here should pay for itself and should ultimately save the federal government money. We have to make that argument early and often. The question is whether it will prevail. The second piece is we are already spending money on hepatitis in various pots. For example, CDC has a division of viral hepatitis that has a line item. That has not initially been targeted, but there are some other spending cuts that might have a downstream effect. For example, proposed cuts coming out of the House of Representatives to parts of the end the HIV epidemic budget. And while HIV is in the name, I think that what we've learned about on these calls and elsewhere is that a syndemic approach means that a rising tide lifts all boats. When you build out the infrastructure for vaccination and immunization, when you build it out for HIV, when you build it out for substance use, you're laying the foundation to integrate hepatitis C and STIs and maternal and child health and all these other things. It's all connected. So while we looked at the bills that came out for spending next year from the House and the Senate, and part of the reaction was who the specific hepatitis line items don't seem to be cut. We can never be like, no virus is an island, in the sense that these are all affecting the same communities. And so anything that weakens one pillar of the community response is going to make it much harder to move forward with hepatitis elimination.
But okay, so then, all right, so let's say this, right? So you guys also did, and I'm sorry if people are offended by the terms guys, but I use it all the time. But your organization, didn't y'all do like a hepatitis C state report card or something like that? Didn't y'all do that?
Yeah, I mean, we've done a couple of different projects along those lines, and I will just like my colleague Adrian, who spearheads our Medicaid work in particular. But I think the bottom line of the story is that I put a link in chat to CDC's latest surveillance report. And just talking about hepatitis C, hepatitis A, hepatitis B, both also important, but hepatitis C, since that's the topic of the White House proposal, a lot of the numbers are going in the wrong direction. CDC and the rest of the government wants to reduce the number of new infections for hepatitis C, but they're going up. And this, as you noted, Tony, is a predictable consequence of the evolving and unfolding overdose and substance use crisis. But also CDC put out data that the number of people getting treated on an annual basis is not where it needs to be if we're going to hit those elimination goals.
Right.
And that those numbers are actually probably going in the wrong direction, which is why this plan is so important, because it could jumpstart the ability to treat many more people.
Right. So Daniel, you're kind of getting to where I want to get to, and and I'm like, Adrian's like, they ain't invited me to the call, so I don't know why she's bringing up my name. But what I wanted to do is so one of the things I'm thinking about here is that, okay, we got a bill that's coming in so that people can, shake the 11 billion out of the federal coffer. We know that we've got these Hep C elimination plans, but are there states, Adrian, that are doing better than others that we can, particularly though, those that are in Appalachia, are there things that we can do to get a conversation going in the states where we need to get a conversation going, where there may not be a conversation going? Even though many states, West Virginia and others, have created Hep C elimination plans, but maybe those plans are like, the way you eliminate Hep C is you put everybody with hepatitis on a bus and move them to New York. Maybe that's not a good plan.
Thanks, Tony. I am used to being put on the spot by you, so this was expected and totally okay. Hey everyone, I'm Adrienne Simmons, she, her pronouns. I'm the director of programs with NVHR and work very closely with Daniel. To Tony's question around, are there states that are doing this well? Daniel mentioned that we have a project that's been tracking hepatitis C treatment access in Medicaid programs across the country for the last 6 years in collaboration with a team up at Harvard Law School. I will put a link to that in the chat, but you'll see very quickly, if you take a look at the map, you scroll down about halfway down the homepage, you will see that there are states that are green and there are states that are yellow, orange, and red, right? And so the states that are green have very positive hepatitis C treatment policies, at least within their Medicaid program. And states that are closer to red don't have so great of policies. You probably won't be surprised that the Southeast in particular has a lot of yellow and orange, which means that there's a lot of work that needs to happen in Appalachia in order to increase access to hepatitis C treatment. There are some states, though, that have made a lot of progress in these regards. Virginia and Louisiana, you'll notice, are both green on the map. And so certainly when thinking about, if you're experiencing challenges with hepatitis C treatment in particular in your state, take a look at this map and see who looks good and reach out to those folks to figure out how they got their policies where they are. It certainly takes a lot of work, combination of advocacy, sometimes litigation, but also just internal champions within Medicaid and the Department of Health to really move this work forward. So this is specific to hepatitis C treatment access. Obviously, elimination is more broad than that. And we could have a whole separate conversation about who's doing well or not as it relates to eliminating viral hepatitis. And I think that that's very relative and subjective. And really the key takeaway is that all states are severely underfunded as it relates to viral hepatitis services, and everyone needs additional resources.
Right. So here, and speaking of putting people on the spot, so Trisha and Kelly, you're getting ready to get put on the spot, and they're like, "What's this got to do with me?" And the reality for us is that Trisha's doing, and Kelly and her and the team and the policy team is doing a bunch of work around the opioid. You told me is remediation. I'm not supposed to say settlement anymore. They're trying to teach me so many things. But I'm wondering, in the 13 states where you're doing work around this, are the rates of hepatitis C and the opioid remediation dollars, are they having any, can they have, are you seeing any patterns where a part of what they want to do with these resources is address hepatitis C?
I haven't seen a lot of examples yet of actual spending decisions made, but I have had folks reach out who are interested in using money for that purpose, and it absolutely could be an approved use of funds. When you look at that Exhibit E document, which we can drop in the chat, that's related to most of the settlements, funding for infectious disease prevention, testing, treatment, et cetera, is listed in there. So again, it is an approved strategy, but I think a lot of local governments haven't really been thinking of the money in that way. They're really thinking more like, like primary prevention and treatment and enforcement. And so a lot of the work that we've been doing is talking with advocates around the region about their need for them to talk with those local government officials who are in charge of the money, explaining all the connections, and making an appeal for money to be used in those ways.
Right. So Tim, I'm gonna come back to you, because see, this is one of those things that I think is a policy issue, right? How is it that, because each state, whether, it's in the Appalachian region or anywhere else in the country right now, is saying, basically we're going to come up with our own plan of how we spend our opioid remediation dollars, that how we're going to spend that. But it seems to me that if we have a hepatitis C crisis, if we have a hepatitis C problem, and we have these resources that are coming in, and we can make a direct correlation to how this even came to be, the opioid crisis and hepatitis C, why is that not a priority for us as a nation?
Yeah, I wish I knew. I mean, my sense is that, it's great that states are trying to tackle this on their own, but it's clear from your conversation with the NIH that, it's not going to be enough. And we're going to need a whole national approach if we're really going to get to those who are most at need. Those in the Appalachia, and those who are in prisons, and those on reservations who really don't have the access that they need to healthcare in general. And they need this approach where you would get tested, get the medication, and ideally take that medication once a day for 12 to 18 weeks and be cured. And so I think a state-by-state approach isn't going to be sufficient. And as you see from that map, that great map, I hadn't seen that before, it's so different in terms of who's doing what for the population with Hep C. And it's interesting, Louisiana is doing well, and that's partly because Senator Cassidy was formerly in Louisiana doing that kind of work, and he understands it. So that's why I'm hopeful that he will carry the water here in Congress to try to get this done.
Well, now that we're here, we know that this, I like to always saying it's a bill on Capitol Hill. So we know that there's this bill up there, right? We know that the reality for us, though, is that many of us are doing work on the ground. We're doing work for education. We're doing work in policy. We're doing work in treatment. We're doing work in cure. We're doing work in harm reduction. So what I want to ask you all, and I do mean all, I'm saying Tricia, Daniel, Tim, Adrian, and what I want to ask you is, what do we really do, right? Because in so many ways, these elimination plans are so, in my opinion, this is just my opinion, and they don't pay me for my opinion. Actually, they kind of do. Is that it's all really theoretical, right? It's so big. These plans are so giant. They're so huge, and they've got 15 points. We're going to eliminate hepatitis C, and there's point 1, 2, A, B, 4, down, 9, 6. And what it really means is that organization X is going to do more Hep C testing. Okay, but there's 15 other bullets there. How are those all going to happen? So what I want to hear from each of you is, and be as pie in the sky as you want. Like, what do we need to do to eliminate hepatitis C in the United States of America? Or mainly, in the case of this call, what do we need to do to eliminate hepatitis C amongst 26 million people in the Appalachian region? That's the question. What do we do on the ground? What are our strategies? What do we tell community-based organizations? What do we tell MAT providers? What do we tell primary care docs? What do we tell people looking at these opioid dollars? What do we tell local and county government? How do we actually get to your, I hear you, Daniel, it's not really every person, it's 90%, but on a Tuesday, I got it, okay? But how do we do even that? Practically, tactically, tell me.
Okay.
I'm
I'm
gonna start with you because I didn't let you talk before, but now I'm gonna let you talk as long as you want to talk until 3 o'clock.
You say that, but you will roast me if I talk for more than 3 minutes. I know you, Tony. So I'm going to start here and say that it's relatively simple or deceptively simple what we need to do. We need to prevent new infections. We can do that through harm reduction and treatment, right? We need to diagnose undiagnosed cases. We can do that with new diagnostics. And then we need to make sure that everybody diagnosed now and in the past gets linked to treatment and cured. That's a 2 to 3 month course of treatment that's completely feasible. All right, so that's the deceptively simple part. If it's so deceptively simple, why has it not happened yet? This is my theory. My theory is that we have such a burden of hepatitis C, but nobody accountable for making sure that it's addressed, right? So health departments are tasked by CDC to bring together stakeholders like they did in West Virginia and develop a plan, right? But every health department starts off, health departments are under the governor, they're political institutions. They're fantastic health commissioners, fantastic public health professionals, really dedicated, smart, passionate people. But they all start within the political constraint that we can't commit to doing more things than we know that we have the money for. We can include some aspirational goals, but that 15 bullet point list that you're talking about, Tony, some of that's like, might as well be an Amazon wish list, right? Or, a GoFundMe. So I think the route to get there is, like Tim says, we've got to get big. We've got to treat this as a systems level problem, that if we try to put a little bit money here, a little pilot program there, we learn a lot of things and we get the experience and know-how to start to imagine what something more robust could look like. But the dam won't break until we bring the money home to our communities, right?
Okay.
And that what everybody can be doing right now is getting smart about this, learning about the White House plan, talking to each other, kind of reflecting on your stories and what you would tell the policymakers who are ultimately going to be deciding thumbs up or thumbs down on this bill, this initiative. And the bill is still in the incubation period, but that, proverb, it takes a village. It's going to take a village of us to raise that baby bill to a full-fledged law. So this is why this has to be, even if your focus isn't on hepatitis, hepatitis connects to your issues, right? Hepatitis connects to all of these issues: rural health, tribal health, maternal and child health, immigrant health, all of that stuff. There's going to be a piece of that where we will call upon you to raise your voice, share your story, make your position heard to Congress. And a lot of people doing a little bit is how bills get passed.
So, but Daniel, here's the thing, right? So a lot of people, not everyone on this call, but a lot of people on this call are small, right? They don't have a policy shop. They don't have a Tricia and her team, Ali. I mean, she would be like, yeah, tell me where the job's at. I'll be over there next week, but that's okay. But, I think that the thing is that they don't have a policy shop. They don't know how to kind of do this, like, rise the all boats, lift all tides, or whatever you said about a policy issue. How do they practically do that? I mean, do they call you? Do they call me? Who do they call? Their Uncle Willie? I mean, who are they calling?
Tim, do you want to respond to that?
I mean, the easy answer to that is they're calling their members of Congress, either their 2 senators or their representatives. And we have materials for, to talk, they've been put in the chat here to talk about what is this program and why it's important. And the more people that just pick up the phone and talk to their congressional office or write a letter or, make the point or meet with their member of Congress, ideally, or go to a town hall, the more likely it's going to happen. Now, the good thing is, I think, at least in West Virginia, both of your senators seem to understand this problem and understand what's going on there in West Virginia. So you have an advantage there. You have two senators who actually know what this program is and why it's important. And I think if they hear from more and more of you, they're apt to say, to turn to Senator Cassidy and Senator Van Hollen and say, let's go, let's get this bill moving.
Okay. Now, could our senators in the different Appalachian states, is this a bill that they could co-sponsor in some way?
Yeah, that's exactly what we'll hope to be able to ask all of you to ask your members of Congress to do once the bill is introduced, for sure. We want to get as many co-sponsors on both sides of the aisle. That's really important these days in Congress. And I think we can achieve that. We've had some really good meetings on Capitol Hill with folks from both sides of the aisle. And I've only had one meeting where the staffer just seems sort of bored, but almost all the other ones, they're taking copious notes. They're very interested in this. It makes sense to them that we would reduce the cost of the burden of Hep C through this kind of investment. So I think this is one where we might actually be able to get Congress to move this. I don't know how quickly, but it just requires, as Daniel said, everyone speaking up and saying, let's get this done.
Right. All right, Adrian, I'm going to come to you then. Trisha, you should get ready because I'm coming to you after Adrian. Adrian, so I'm wondering, because here's what I've always believed. And so this is the stuff that goes on inside Tony's brain, which you probably don't need. But I always kind of thought that one of the reasons that we as a nation were afraid of hepatitis C was because we thought that the nation thought that there was going to be this run on Hep C treatment and Hep C cure, and it was going to burden every state Medicaid, Medicare system, and that people were just going to be running down the roads. Give me that Hep C med, give me that Hep C med. And it was going to just run every budget over. And I'm like, is that even remotely possible? Is that even true? Like if every person ran to the state health department to get treatment right now, is that what the problem is? I mean, and how do we get people away from that sort of thinking?
Yeah, it's a great question. You're speaking to this, opening of the floodgates myth, right? That the minute we reduce some of these barriers to treatment, that people are going to be busting down the doors asking for treatment. And the reality is that in states that have removed barriers, either incrementally specific to, say, substance use or fibrosis requirements, or we have a large number of states now that have removed prior authorization as a whole altogether for most patients. So we're up to 25 states now, nearly 50% of jurisdictions have removed prior auth. And what we've seen in those states—
Whoa. You know we don't do that here. We don't do that. What is prior authorization and what did you just say? Because there are people that are going to be texting somebody saying, what did that mean? And we don't want that.
Yeah, we don't want that. So prior authorization is an administrative process that when your doctor writes you a prescription and you take the prescription to your pharmacy to get it filled, they submit it to your insurance company and your insurance company says, wait, we need additional information from your provider before we will pay for this medication. Your doctor needs to prove that you do in fact need this medication by submitting paperwork, lab work. Sometimes it involves phone calls to the provider. And so that's overall what a prior authorization is permission from your insurance company and in coordination with your doctor to pay for a medication or a service. And so prior authorization has been used in hepatitis C treatment to really limit access to treatment. There have been specific criteria like you must be abstinent from drugs and alcohol for 6 months in order for us to approve your treatment. Or you must have severe liver damage, or you must see a specialist like a hepatologist or an infectious disease physician before we will pay for your treatment. And so because at every step of this process, there's an opportunity to lose someone to follow up, right? It typically takes days, oftentimes weeks, sometimes even months for patients to make it through this prior authorization process. So that's the game of phone tag between your provider's office and your insurance company. In most cases, your prior authorization might be approved, but for folks who have unstable access to phones, unstable access to transportation, right? They may not be able to get back to the doctor's office to provide additional lab work, or and they may not be able to get to their pharmacy or even take a call from their pharmacy before they're able to ship their medication out, right? There are steps to lose people in all of these aspects. And so what we've seen in states that have removed that administrative process entirely is that the floodgates haven't opened. There isn't this just, magical kind of swipe of a pen that results in everyone in your state getting access to hepatitis C treatment. Usually we will see kind of a temporary increase because there have been folks that may have been waiting to access treatment for a long time, but those treatment numbers usually level off relatively quickly. And so, my theory is that removing prior authorization helps streamline care for people who are already engaged in care. It simplifies the process for people who have already been engaged. But
you have a question in the chat. What's the deal in West Virginia with prior authorization?
In West Virginia, you still require prior authorization, and there are specific requirements related to substance use as well as to retreatment. I will put a link in the chat. If you go to the link that I put in the chat a little bit earlier, you can see report cards for every state, but I put a link to West Virginia's in the chat, and it'll give you kind of specifics on what the West Virginia policy says. And so ultimately, we don't think that removing prior authorization magically finds all of the people who are living with hepatitis C in your state, because really that depends on us testing more people, right? In order to treat more people, everyone has to know their status, and we do a really poor job of testing people. But removing prior auth does in fact simplify access to treatment and care for people who have already been identified and diagnosed. And so we have not seen, states' budgets be blown up by removing these barriers or removing prior authorization overall. And in the context of the cost of medication having come down significantly, states are more willing to remove some of these barriers. So I'm going to put a link in the chat to a fact sheet that we have about the cost of hepatitis C treatment. Hepatitis C treatment, when it came to market almost a decade ago, it was about $100,000 per treatment course. But now you can reasonably purchase a full course of hepatitis C treatment for about $15,000 to $20,000, and sometimes even less if you live in a state that has any sort of contract with a manufacturer, or if you're using the 340B drug program. So put a link in the chat to a fact sheet that tells you more information. But the short answer to Tony's question is that removing prior authorization does not automatically open the floodgates, and that ultimately we've got to test more people in order for us to treat and cure more people as well.
Okay, I'm having a bit of a challenge with my camera, so hopefully you can hear me. And so Tricia, I'm going to go to you next, because I think that there's also the impact of what's happening with the opioid remediation dollars. And what do you think we should be doing?
Well, when it comes to Tony, you can say opioid settlement, that's fine. Just don't say settlement. When it comes to opioid settlement dollars or opioid remediation dollars, my biggest interest is that these funds, because they are so unique and do not come with a lot of the restrictions that come with other funding sources that we often see from like state and federal governments, that we really should be thinking about how those funds can be used to fill gaps where those other funds either can't be used for, or, there's some weird hoops you have to jump through. And so when that comes to thinking about hepatitis C, that's what Daniel had already mentioned, like funding harm reduction, right? Like funding community organizations who are really out there talking to folks who aren't really brought into care in other ways. To eliminate hepatitis C, we obviously need to be thinking about all of the different pieces and all the different touch points. If we're thinking about the Appalachian region in particular and how rural it is, like a lot of folks are not going to see a variety of specialists. So maybe it is working with the very small primary care physicians and getting them engaged. Maybe it's working with these small community-based organizations who are out doing street-based outreach and being able to fund these folks who don't have other funding sources. It could be used for a lot of different things depending on what makes sense in that community, but really thinking like strategically about it instead of just sort of passing it off to the first opportunity.
Right. Right. And so folks, there's a major storm that's here and my lights are flickering, which is why I think is what has happened to my picture on my phone. But in case I get lost, I'm sure somebody from CET's team will take over, or Daniel Raymond will use his leadership skills and wrap this up if I get knocked off the call, is my point. Listen, I guess I keep thinking that we don't really kind of acknowledge a care continuum to cure around hepatitis C, right? Like, we have the HIV continuum all the way up, and then they started to add even PrEP on, PrEP is treatment, PrEP is prevention, PrEP is, and so now we've got that, but you don't see the same kind of continuum around hepatitis where you get all the way to cure and you have all of the partnerships. So I guess that's my next question for everybody is, who are these partners supposed to be to get all this work done? Where are these people at?
I can take a stab at that, Tony.
Okay.
So here are places that could be those hubs or sites of care. Community health centers, opioid treatment programs, and other kinds of drug treatment programs, harm reduction programs, certain services programs, reentry programs, healthcare for the homeless, like lots of different places. Many of them, we have models to point to say, this is how you make it work here. This is why you need a peer. This is why you need a care coordinator. This is why you need to address transportation or telehealth or whatever makes that work. The thing is that the financial incentives don't line up. So you'd ask towards the beginning why there aren't more drug treatment programs doing this. Drug treatment programs have largely culturally and institutionally been carved out of the rest of the healthcare system. And so just like anybody else, when you're delivering health services, you want to be able to make sure that you're financing that responsibly and that you're getting paid for your work. A lot of drug treatment programs are not set up to tap into reimbursement, Medicaid, Medicare, private insurance in the same way that other kinds of clinics and hospitals are. And they would have to kind of do a whole lot of work, whether it's in terms of licensure or certifications or upgrading facilities or getting the right kind of laboratory equipment and staffing in place to make that happen. And so there's a kind of chicken and egg problem where a lot of people are willing to raise their hand and step up and say, you know what, I could do more about hepatitis C if I had some help, but the money hasn't flowed down to make that make sense for everyone.
So Daniel, let me ask you this question. And is one of the pieces of advocacy work that we need to be doing also that there are more resources for existing healthcare organizations to be a partner with us in this fight?
I would say yes, whether we're talking about the White House plan or broader public health strategies. One thing to remember, the White House plan says we can do this in 5 years. And that might sound wild, but for a curable infection, it's conceivable. But in a 5-year window, you're not talking about building out a whole lot of new programs. You're talking about working with the infrastructure that exists, whether it's the Ryan White Clinic over here, whether it's Indian Health Services facility over there. And so we've got to start mapping who's out there who could be positioned to take this on so that when we're able to mobilize the resources and the political will, we know where it should go.
Huh. Well, and so, okay, so what would how do we do that, right? How do we do that? How do we map out where the holes are in this and that we need to patch?
I think there's probably a few different approaches. Every state does some degree of surveillance for hepatitis C, and really like trying to talk to your surveillance people and see how granular they can get about where the numbers are, where people are being diagnosed, where they think there are hot spots, and where they're not sure because testing isn't happening. We could see more testing through emergency departments, for example. We could see more testing through drug treatment programs. We could see where those gaps are and who's getting diagnosed and who we think we're missing based on national projections. But we could also start talking to our colleagues in organization to organization within communities. You don't have to wait for me or Tim or Trisha or your state health department to bring together your colleagues and say, hey, let's talk about hepatitis C and pool and share what we know, right? And what stories we have to tell. Because a lot of people have some experience, whether it's a client or a cousin with hepatitis C. Once we start to share and find those common denominators, then we start to be able to uplift what our communities specifically need, what we had that worked and what we lacked that we need.
This
And
rising tides with all boats thing is really working for you today, isn't it? You just rising boats and lifting up, and
I must be in need of a vacation on a
on a
cruise or
cruise.
something
A
like
cruise.
that.
That's what I'm thinking.
Yeah.
You really need a cruise, because I'm like, you rising tides and lifting boats in a couple of different scenarios here.
Yeah, and one thing that I will mention is that just as hepatitis C, like everything else, isn't a one-size-fits-all problem, that we're going to need a lot of different tools in a lot of different places, but the politics is also not one-size-fits-all. Different elected officials, different members of Congress need to hear different messages. So Tim and I work with colleagues at ASLD, the American Association for the Study of Liver Diseases. They said, you know what, we think that we need to make the case that hepatitis C elimination is a rural health issue. And so they're going to be working on a sign-on letter that we'll get out to all of you to circulate, all of you who work on rural health, work in rural areas, to make the case, because there's a lot of members of Congress who represent rural areas. And some of them might be saying, oh, this sounds like a big city plan. This is something for the New Yorks and LAs and Chicagos and stuff. But we want to make the case that this is going to be especially important for people in rural areas, and we can make it work.
Thanks, Daniel. I appreciate it. Tim, you look like you're ready to chomping at the bit. Go, Tim, go.
All right. There's just a good question in the chat about the test. So there is a test in Europe, but there has not been a rapid test that's been approved for Hep C by the FDA here in the US. The White House thinks that that can be done this year and created and used, but it does not have to be administered by a doctor or a nurse. It could be administered by a physician assistant or folks who are in a clinic. It's going to be kind of like your COVID test. So it should be relatively easy once it's out there for people to use.
Perfect. Teresa, was that your question? Okay, perfect. Does anybody else?
Thank you.
All right, we have about 8 minutes left. If anybody has a question for any of the panelists or anyone, if you could either raise your hand or put your question in the chat, that would be great. Because my last question for you all is, what's a world or a country or a region look like without hepatitis? What happens? What are we looking like? What does that mean? If we achieve the goal, what does that really look like? Am I making sense?
Yeah, Tanya, I'm going to tell you a part of this story, and I'm interested to hear what other people have to say. One thing that we learned a while ago for people who use drugs, that some of them were apathetic about getting HIV tested. But if you said, hey, we're also offering hepatitis C testing, that was a draw for them. And what I take away from that is that hepatitis C status is very important to people who use drugs, people who inject drugs, and it can be a motivator for them to start taking broader steps around managing their health and improving their relationships with the healthcare system. We see this particularly with people who are using drugs or in early recovery, that getting treated and cured for hepatitis C can be a powerful motivator for them, especially when they've experienced a lot of stigma or even discrimination in the healthcare system, that it starts to give them the confidence that not only can they kind of take control back over their health, but the things that they might have been neglecting or avoiding or having bad experiences with the healthcare system in the past that they don't want to reproduce, it actually strengthens their motivation. If they're in early recovery, it supports their recovery journey. So I think when we talk about a world without hepatitis C, it's easy to think about the money that we save to the healthcare system, the lives that we save, the cases of liver cancer that we avert. But it's just as important to think about those personal journeys and how they support the broader goals that we all share for healthier communities.
Perfect. Tim, what's the world look like without hepatitis C in your mind?
Well, I think it just really means that we're going to eliminate a lot of people's suffering, in the sense that, you know, if you get hepatitis C and you don't get it treated, you're going to get liver disease, and you may even have to get, you know, a transplant, all of which are probably unattainable for a lot of the people we're talking about who have hep C. So it really means that the vast number of people who have hep C won't have to suffer those consequences, which, you know, will save money, which is great too. But I agree with Daniel. It's about the people who have this disease that is curable. I mean, and what a great thing we could be able to say and lead to the next treatment for something else down the road, to say, look, we took this on and we cured this disease, and people, you know, we basically eliminated it in the US, and hopefully in the world. We see examples in other countries where they're doing this. So I just think it would be an amazing accomplishment.
Tricia, what's it going to mean for the opioid settlement people if we could eliminate hepatitis C?
I wish I had as inspiring of an answer as Tim and Daniel.
Okay.
I mean, I think that unfortunately a lot of education still needs to happen among the folks who are in charge of the funds, right? These are the folks who are much more concerned about the bottom line. And I'm not really sure that the county level officials even would have a solid understanding of the price point of hepatitis C in their community. I imagine that there can be, you know, some talking points in that direction to get them to understand. But I mean, I kind of subscribe to Daniel's larger point of, like, this is a way to invest in our communities, broadly speaking, and in our community health. Unfortunately, not everyone who, without the public health background or emphasis, understands that intuitively.
Okay, got it.
Hey, Tony,
Tim?
can I say one more thing? And that is,
Tim, this is your party. You can say whatever you want to say.
thank you. I put a little clip in there from CBS News about the hepatitis C elimination program. And at the end, Francis Collins says that he's obsessed with trying to get this done. I feel the same way. I think Daniel does. We want all of you to be as obsessed as Dr. Collins is to eliminate hepatitis C, because it is doable. And I cannot thank you enough for this call. It's been a great call. Tony, I look forward to working closely with you going forward. And, you know, I'm really happy you had us join.
Thank you, Tim, and thank you so much. And if you would do us a solid, and that solid is, if you have action items, if you have things, you know, like you're talking about now, hey, call your member and talk about this. If you have tools, if you have trainings, if you have anything, let us know. We will promote it. We will, you know, do our best to get folks from the Appalachian region there to be a part of it, to make sure that their voices are heard, that our voices are heard. You know, I mean, that is why we do these calls. We do these calls so that folks that are in community, that are on the ground doing work, have access to people like you, have access to people like Adrian, have access to people like Daniel, Raymond, but also understand that we are in this all together, right? You, like Tricia, like all of us, you know, so it's like all of it is really about how do we work together to do something like eliminate hepatitis C in the Appalachian region. Because I always go back to the first iteration of the National AIDS Strategy. The National AIDS Strategy, for better or for worse, for good or bad, has one line in it that I think is the line that culminates with why we do what we do, how we do it. And what it says in there, and I'm gonna probably mess it up a bit, but it says that we can't do this alone. It says that the federal government can't do it, community-based organizations can't do it, researchers can't do it, academia can't do it, people with impacted with lived experience can't do it alone. The only way we do this is if we do it together. And so that's why we do this, is because the only way we do whatever we're going to do, eliminate hepatitis, address substance use disorders, stop the train in its tracks that's roaring through Appalachia. Only way we do it is that we do it together. So the only way we can do it together is that we know what each other's doing and that we rely on each other to get it done. First and foremost, thank you all for taking time out of your day to join us. Tim, you're now in the CEG Army. I don't know if they explained that to you.
Looking forward to it.
All right, and Tim, I want to again thank you. Anything you need us to do, please just let us know.
We will.
Daniel, as always, it's been more than a 20-year journey. I love you, brother. I love everything that you do.
Love you
And
too.
Trisha,
I still feel like I'm in CEG boot camp, but it's been a pleasure.
but Trisha, thanks so much for the work you do and are doing in opioid abatement and settlement work. And Adrian, I think Adrian had to jump off. But again, thank you all for staying with us all for the hour, and have an amazing week. Thank you all. And we can eliminate hepatitis C in the United States of America and in the Appalachia region. See y'all.